Hello everyone, my name's Connor. Thank you for joining our quality improvement meeting. I'm here with my colleagues, Catherine and Mia. They'll be introducing themselves later throughout the presentation. I want to get things started by introducing our current QI project. So one of the things that we've noticed an uptick in is the amount of hospital readmissions that are following inside that undesirable 30-day discharge window. In our eyes, this signals a significant gap in patient safety and care quality during that vulnerable transition from hospital back to home. One of the ways that we were looking at improving our outcomes is by improving the standardization of our discharge paperwork. Along with this, we have been looking at ways to improve the capabilities of our electronic health records to identify patients who are at higher risk for admission. Looking at some more data, the Agency for Healthcare Research and Quality has identified that readmissions often stem from fragmented care. Despite national efforts like the hospital readmissions reduction program, 27% of hospital readmissions are still considered avoidable. These could be prevented if we're better integrating primary care and outpatient services into our discharge planning. This 30-day window after discharge is critical. The Joint Commission reveals that only 68% of patients are currently receiving complete discharge instructions. That leaves the remaining 32% at significantly increased risk for readmission, simply because they weren't given the full tools they needed to succeed at home. From here, I will hand it over to my colleague. We can continue the presentation.
So what we found is that discharge is often really just kind of a checklist of simple tasks that we need to complete before discharge, and that really includes scheduling those follow-up appointments, making sure they've got their referrals, sign off from pharmacy, sign off from PT or OT, and then the nurse printing off that form to give to the patients and then giving them their education. And that education is often kind of a separate sheet, and it's really only available in English or Spanish. The languages are a little bit limited, and so patients are often being quote-unquote discharged to fail, which really means that all of the aspects of discharge aren't really being addressed too much, including verifying that they actually understand their discharge, or determining social determinants of health, like if they are able to actually get to their appointments, or if they need help financially, wherever it may be. And because of that, patients do return to the ER very quickly after their discharge with often worsened conditions. So some recommendations we have: one would be just standardizing the teach back protocol. I mean, we've seen that teach back is very effective with patients. So just asking them if they explain their diagnosis and the medications that go along with that and any follow-up appointments, and it just kind of helps them have a better picture of what their discharge looks like, instead of just asking, do you understand? Standardizing this could be modified within the discharge papers to include those questions that have those knowledge gaps, or even within the high-risk diagnoses. Second recommendation would be a post-discharge follow-up. So that would look like a nurse calling the patient about 48 to 72 hours after their discharge, and they could really just call and focus on their symptom management, how are they adhering to their medications, and confirming any follow-up appointments that they may have, and if we do need to reschedule those, assisting with that, and then making sure that they're able to get to those appointments. And it really just kind of keeps them on track for their after discharge care, and it can kind of help us identify some of the early complications that could happen. And then the last one would be kind of a comprehensive medication reconciliation. So that would mean we would just look at their medication list and try to identify any duplicates or errors prior to actually educating the patients about their medications. We could collaborate with pharmacy for the high-risk medications, and this significantly reduces post-discharge confusion and non-adherence in older adults. It's shown that medication non-adherence and confusion is one of the biggest reasons why patients do come back to the ER after their discharge and have more complications.
The way we are thinking of evaluating the effectiveness of our interventions include taking a look at the 30-day readmission rates, where we do monthly audits to track if the new protocols are correlating with a decrease in readmission rates. Secondly, looking at the HCA-HPS scores, where we specifically look at the care transition and discharge information sections of patient satisfaction scores to see how patients feel at the time of discharge and with the care that they got. And then lastly, looking at staff compliance, so this includes doing audits in the EHR charts for documented teach-back sessions and completed 48-hour follow-up calls. But the risk of maintaining status quo would include not having a standardized discharge planning process, leaving 32% of our patients to leave the hospital with incomplete instructions, contributing to an increase in readmission rates. Secondly, patients may feel like they are discharged to fail, which can lead to a lack of trust in the healthcare system, leading to non-compliance and then worsen long-term health outcomes. And then, there is a program too to help reduce readmission rates, and this is the Hospital Readmission Reduction Program from CMS that fines hospitals if their readmission rates exceed the standards. But if we start implementing changes in our system, we can have benefits which include proactive transition management, reducing readmissions, increasing the bed capacity for elective procedures, and new acute admissions. We will have more standardized planning that identifies barriers like medication confusion before they result into an emergency room visit, which helps us focus our care to more patient-centered care. And then lastly, by also meeting the Hospital Readmission Reduction Program standards, this facility also avoids having CMS penalties or fines.